Good morning, everyone. Happy Friday, happy Friday, happy Friday. I'm Clay Farris, bringing you Medicaid news for August 28th, 2026. If you're new here, I'll do Medicaid news recap. I'll show you some job listings that we think you might find interesting. We'll do acronym of the day, and then we'll do Mission Possible. Also, if you're new here, don't forget to get your copy of your weekly Intel report. It's got Curator, where our team is finding and processing and summarizing and highlighting all the Medicaid news for you. If you'd like to follow along, I also call out the numbers in each week's Intel report for the stories that I'm covering here today. There's lots more that we put in the Curator and in the Intel brief than I'll be able to cover today. But if you're not signed up, the way you find them is find your Medicaid LinkedIn, your Medicaid on the Brain LinkedIn community group. You can see it up on the screen, and then you'll get on the distribution list. I'll cover some MCO news first. Our first item in MCO news is number one in your Intel report. Investor suit says UnitedHealth ignored governance and cybersecurity for years. I think we all finally realized how bad it was at the Empire when the massive cluster that was the Change Healthcare data breach happened now a couple years ago. Remember, United at first tried to pass that off and even got us all to call it the Change Healthcare data breach instead of the United Healthcare data breach. The biggest smoking gun in that breach was that United never even implemented multi-factor authentication at Change Healthcare that it had bought. There's other things in that story that I'll let you look back up on the background, but more things that come to mind is, United didn't even want to pay the cost of doing the mailings to let providers know. They had to be forced to do that by a judge. So now fast forward, and some of the fallout from that is happening a couple years later. There's two different plaintiffs that are suing United, and they're both institutional investors. One is the pension fund for Rhode Island, and another is a Swedish asset manager that I can't pronounce the name. So they filed a complaint August 7th, and it's hinging on some confidential witness testimony from inside United that says the transition period post the acquisition of Change Healthcare was deliberately rushed. It was a strategy because they knew they were trying to beat the clock on a DOJ investigation that was trying to block the deal. So according to this whistleblower, United Health wanted to make it sort of an undoable thing so they wouldn't be able to pull the two apart. So the DOJ couldn't block it, and if they got the companies fully entangled, so they couldn't separate them. This new lawsuit says that Hemsley, that's the UnitedHealth chief executive and board chairman, specifically supported another deal that got rid of an internal audit program that exposed United's $200 million risk adjustment shenanigans in other areas. So what we're looking at is a lawsuit that claims there is a culture not just of negligence, but of deliberate wrongdoing to get away from the law. Our next MCO news item is item 3. Kansas did not ensure that its Medicaid managed care organizations complied with mental health and substance use disorder parity requirements related to prior authorization. Many of you know the basic facts of this one, but OIG looked at this, and Kansas does not really even have policies or procedures to do what it's supposed to do, let alone guidance on how they should review parity. And if you're not familiar with parity at a high level, states are supposed to offer the same support and level and controls and authorization and benefits of services for mental and behavioral health as they do for physical health. This has been an ongoing issue now for at least a decade that I know of, and I think behavioral health folks would tell you it's been the law for the parity has been the requirement in the law for much longer, and that the states have to do this, and few of them do a good job at this. And according to the article that we have in the Intel report, there's one of the MCOs denied at a higher rate for things related to mental health and substance use disorder that similar things in medical and surgical requests were getting denied at. It's not just Kansas. There's other work that showed CMS is not doing what it needs to do for 8 other states to have the types of policies and procedures in place to even review the stuff. None of the MCOs in Kansas were able to even provide a report, an analysis of how they were doing on parity, so they don't have any idea of how well or how poorly they're doing on this. So OIG is asking for simple things like forcing the state to have the MCOs actually submit the parity analysis reports and implementing policies that clarify basic things like which agency is responsible for overseeing this. So let's move on to our last item in MCO news this week. It's going to be item 4, payers ranked by prior authorization denial rates. The headline here is that insurance companies deny anywhere between 12 and 18% of on aggregate standard prior authorization requests in Medicare Advantage and Medicaid managed care, an ACA marketplace, or exchange plans, at least for the year 2025. Most of those denials get appealed, and there's a wide range. So LA Care denied about 2%, and Independence Health Group denied about 23%. United Healthcare said, my bad, more than most, and ended up overturning 81% of its appealed Medicaid denials. So people just make sure you appeal. In aggregate, about 67% of Medicare Advantage initial denials are overturned. And about 47% of Medicaid managed care initial denials are overturned, and about 43% of exchange plan denials are overturned on appeal. Now, there's some actually good lists in this one that name names, so I recommend checking that out just to give you some data on this. Independent Health Group by far in our Medicaid world was 23% is the highest. Coming in a close second is CareSource at 20%. Did not have that on my bingo card. CareSource is stamping the big fat no denial stamp more often than most. Centene at 18%, CVS at 17%, Molina 11%, United 11%, Elevance at 9%. Now, these lists are in there for the other spaces, too, for Medicare Advantage and Marketplace. I'll let you check those out as well to see other names in there like Oscar and Guidewell and Humana. But for now, let's move on, I think, to tech news. And we'll do item 6 in your Intel report. This is a game changer. Universal Health Services closes $835 million Talkspace acquisition. So Universal Health Services is buying Talkspace for its network of 6,000 behavioral health providers. UHS is projecting that Talkspace is going to generate about $280 million in revenue just this year, so it's only going to take a few years to pay it off, even if it never even scales from where it is now. And of course, UHS is betting that it will, because now you'll have Talkspace virtual providers who are just coincidentally going to be referring into the Universal Health Services facilities. If you're not familiar with UHS, it's one of the largest healthcare delivery systems in the United States. It's based out of Pennsylvania. It has more than 30 hospitals and hundreds of outpatient facilities across the nation. Last I looked at, it was in 40 different states. So if you're familiar with how hospitals buy up doctor groups, this is really hospitals buying up behavioral health provider groups. As a shareholder, this couldn't come at a better time. The stock has been struggling lately. It dropped by nearly a third in just the last 6 months, and they've been lowering expectations for 2026 earnings guidance recently. Didn't really have a lot to talk about in pharmacy news this week, so let's hop on to CMS news. And really, these are just kind of, I think, CMS messaging news. So CMS officials are saying that they're looking at reductions in exchange enrollment, and they're saying that's really driven by recent fraud crackdowns. Other people disagree with them. We'll talk about that, but you can see what CMS is. They say they've removed about 1.5 million people for issues related to duplicate Medicaid enrollment and CHIP enrollment, meaning they were on the exchange, but at the same time they had Medicaid CHIP enrollment in other states, which of course means health plans were getting paid on both sides for the same person. Now, exchange-based enrollment has fallen like 3 million down to now I think it's still almost 20 million, 19.2 million, and the vast majority of those still get near 100% subsidies. But don't forget, we stopped paying the enhanced subsidies, which was just extra cash to health plans recently because they expired. But the health plan, they just could not stomach that, and they still got to increase premiums by 58% on the exchanges in 2025, and the deductibles are now $3,800 a year. I like the quote in here. It says, these are real people who are now forced to make impossible decisions. I think the real question is, who is forcing them to make those impossible decisions? Could it possibly be the health plans who just can't stomach not making the outlandish levels of profit they had been? Anyway, the administration is saying nearly all of the drop that we've seen is because of enforcing fraud or improper payment or eligibility rules like the duplicate enrollment or auto enrollment or sort of ghost enrollees that we've all heard about on the exchanges. There's some that have been removed from the rolls because they didn't file the taxes they were supposed to prove that they got the subsidies over a 2-year period. Critics say, oh no, they're just lying. The administration's lying. There really wasn't that much fraud, and the real driver of people exiting exchanges is increasing premiums. This probably will continue to be a story because there's some groups showing that exchange enrollments might be down as much as 26% this year by the time it's all said and done. All we know for sure is there has been more effort to remove improper enrollments. People are still getting nearly all of their exchange costs subsidized by taxpayers, and health plans get less additional profit than they did before the air quotes enhanced subsidies expired. Let's do one more CMS news item in your Intel report. This is item 8. Almost all custodial parents, caretaker relatives should not be impacted by Medicaid work reporting requirements in 28 states. So this is a Georgetown analysis, and based on their read of the community engagement requirements enacted in the H.R. 1 law, they think that most people that are caretaker relatives or custodial parents are going to get an exemption because they're already meeting the $580 a month household income from work threshold. But put another way, they're already working, and they should be able to easily prove that they are already working. The report from Georgetown lists the 28 states and also lists the regulatory citations in CFR, if you want to check those out, help people in those states be more equipped to comply with the reporting requirements. Let's look at a couple things in state news items in your intel report this week. Check out the map for all the states that we did cover in Curator. I don't have time to cover most of them. First up is actually going to continue the parents as paid caregivers story in Arizona. Now, all that's under review by Arizona auditors. So there's a report from the end of July in which the Arizona Auditor General is raising the red flag about growth in the expenditure and enrollment for this program, in which family members get paid as caregivers by Medicaid. So the enrollment itself, just looking at the facts, grew 106% from fiscal year 2019 to fiscal year 2025. The expenditures rose by more than $500 million over that same period, coming in at $537 million. Lawmakers have started to notice, and they've tried to put some cost control conditions for the additional $83 million they got asked to dole out this year. And House Bill 2945 puts a 40-hour weekly cap on paid parental caregiving. If you need to do more than that, there's a form you got to fill out under extraordinary care. It comes with a standardized assessment. And that tool was required in October 1 back in 2025, but they stopped requiring it, and state agencies, they stopped requiring it. So according to the agency itself, they stopped requiring it because there's a litigation concern and potential conflict with other CMS requirements. The auditors disagree and say, hey, we're really just into cost overruns at this point. And now let's do item 16 in your intel report. Utah's Medicaid program may be facing a $200 million shortfall. So depending on which estimate you look at, it's actually between $100 and $200 million that the Utah Medicaid program is asking beyond what they've already been appropriated for. And this is even after dropping 200,000 members. Those members dropped after the normal eligibility rules got turned back on at the end of years of not using them during the COVID public health emergency. Agency officials say this is risk pool issues, and that the remaining members are sicker and have higher costs. The state has to spend like $500 million a year of its own cash to pull down federal funds. This year it's so bad, the state's probably going to have to dip into what they call their rainy day fund to help bail out the program. Legislators also are not happy that the budget forecasting tools did not predict this shortfall. Our last state news story will do item 17 in your intel report. Virginia Medicaid changes October 1. Cut coverage for thousands of legal non-citizens. So H.R. 1 tightened up the spending on Medicaid for non-Americans, and the impact in Virginia is going to be about 5,800 folks that are asylum seekers, refugees, African visa holders. They're no longer going to be eligible to have their health care paid for through Medicaid. A wide range of other non-citizens but lawful permanent residents are still going to get that. People like Cuban, Haitian entrants, and other migrants remain eligible. And those who lose full coverage are still going to get everything they need in an emergency situation still from Medicaid. They just don't get the full benefits as if they were Americans themselves. So Virginia DMAS is sending out letters at the beginning of August and doing town halls to help everyone that's impacted to understand what's going on. Children under 19 and pregnant adults, even in these groups, are also still eligible and not hit by these new eligibility rules. Let's do one item in reform news. Item 24, mandatory VBC, that's value-based care programs, brought admin costs for hospitals. So this is, if you think about what's been going on in value-based care for forever, we've all been drunk on the idea that value-based care is going to save us money for decades now. And JAMA's starting to look at it and say, wait a minute, what's the actual impact on all these innovative programs? Turns out there's $3 billion additional dollars in administrative costs just to run these that can be contributed to participating hospitals and other programs in this value-based care arrangement scenario over about a 12-year period. So $3 billion, 12 years just to run the stuff from about 2008 to 2020. Now, it's actually $2.78 million in administrative costs per hospital on average for folks that are participating in the CJR model. That's one of the joint replacement value-based care models. The costs go to things like additional staffing needed, workflows for reporting documentation. I'm sure there's lots of software vendors that pop in there to help you run your value-based program and consultants. Cost in the joint replacement group, that's a comprehensive care for joint replacements, one of 4 major value-based care programs in this period. Just in acute hospitals, if you compare them in Maryland, there's 349 there in all 4 models, actually. But CJR ran nearly 3 million more if you're just looking at a participating hospital or not, versus a Maryland acute hospital not participating. Just additional costs to run the value-based care. All this comes at a time that CMS is looking at expanding particularly the CJR program. And it's interesting the researchers make a note that CMS's own analysis of these programs do not even consider these additional administrative costs. So I think we're going to keep doing it. I think we're going to keep drinking the value-based care Kool-Aid, and we're not really going to care how much it's adding up. I do think it's refreshing to even look at or even have studies that look at the administrative costs to operate these value-based care programs that everybody just believes are working, And I didn't go far enough to say, well, net, we offset the $3 billion in administrative costs by X amount in savings, but that would just be crazy to actually try to get a real number on that. If I see it, I will put it in front of you. Let's look at fraud real quick. We'll start to turn the corner. Very low dollars in new cases this week, $1.8 million. The vast majority of those come in Minneapolis, in which a sex trafficking case was tied to $1 million in Medicaid fraud. In this case, we meet Frank Reeves, Andrea Sampson. She was a former county prosecutor. Victoria Comanos, Salman Elmai. He worked in Riva Health, and Catherine Tomes. They all face about 100 felony charges for what they've done to 13 different victims. They ran what is in the articles termed a commercial sex house. It was fronted as if it was an assisted living facility and billed Medicaid for a bunch of stuff, $500,000, and some of them more than $1 million, others. That was called Home Felt Assisted Living. They also ran a group called Riva Health, and that one billed more than $1 million to Medicaid for services that were never provided. DHS stopped payments in about February. Now, that was around about the time that CMS was starting to show up in Minnesota and say, hey, we need to look into some things. I just called this one out because there were all these victims. Remember, this is a sex trafficking ring, and they were also getting Medicaid money. Because as I tell you each and every week, almost always where you find financial fraud, there is a member being harmed. I'll let you check out the details of the rest of the stories in Curator, where we go into various frauds again this week. It's pretty small, but remember, you pay for all of this as a taxpayer. You paid for these people to be harmed in this sex trafficking ring. And if you are the one of folks saying that Medicaid fraud is not that big of a deal, or it's not prevalent, or that pointed out as politically motivated, you are culpable in these types of cases. This is your fault. And now we're going to hear from our guests for this week. Let's check out and see their thoughts on some of these news items. All right, up next, we're talking to Ben. Ben, if you don't mind, kind of give a quick intro of yourself, your work, whatever you want to talk about for our audience, and then you and I'll hop into the stories that we talked about and you want to cover for today. Go ahead.
Absolutely. My name is Ben Miller. I'm a clinical psychologist by training. I have a faculty appointment at Stanford School of Medicine, and I'm the advisory board chair of Inseparable, which is a national policy advocacy organization focused on mental health. Most of my work has been looking at how we can increase access to mental health services and keep it affordable.
Nice. Thank you. I swear we got a fancy one. When you were giving your bio, Ben, I'm like, wait a minute. He's much more credentialed than most of the people that we know.
Got it.
No offense to other guests. I'm just kidding. Thank you for being here today, man.
Yeah, of course. Thank you.
First article, I'm really glad you picked this one. I actually was looking at this in more detail this morning. Kansas did not ensure that its Medicaid managed care organizations complied with mental health and substance use disorder parity requirements related to prior auth. And I actually covered this in my news overview for this week. And I probably botched it, but I think a lot of people don't understand like what is supposed to happen with parity and how long it hasn't been happening and all that kind of stuff. And in my view, that's sort of just this is like a big screen version of that. But I'll let you kind of lay out whatever you want to talk about in this particular story. And please do give a more professional explanation for the audience. So what does it mean when we're talking about parity? What's happening, that kind of stuff.
I got you.
Go ahead.
All right. Well, so for those that don't know, Mental Health Parity and Addiction Equity Act was a law that was passed in 2008, and it was extended in managed care, specifically Medicaid, in 2016. And what it says is that insurers can't make it harder to get mental health or substance use treatment than it is to get medical or surgical treatment. And so that means not in cost, not in limits, not in visits or days, not in how they manage access, et cetera. What's interesting about this Kansas story is that Kansas actually wrote in their managed care contract language that the plans would do these parity analyses to determine if they were actually complying with the parity law. And what the Office of the Inspector General found for the state was that they weren't doing it. So it's just a really frustrating thing. If you're not familiar with what a parity analysis is, it sounds like a mouthful, but it's really simple. It's just the process of comparing how you're doing as a health plan for mental health and SUD services like you are with medical. That's pretty much it. So it's another bullet point on the ongoing data tree on how many times that we've continued to fail enforcing mental health parity as a country, as a state, pretty much as a land everywhere.
Right. Yeah. I mean, and Why is that? I mean, it's now 18 years out, and
I
everybody
know.
that I mean, I'm fortunate enough to have Chris, my business partner, has a behavioral health background, some stuff he's done, and other people I know, and that's basically been the story of like, yeah, Clay, we've been supposed to have been having this for a long time, but we haven't. What's up with that?
Well, what was interesting about this story is they actually kind of point to with the problem here, which is that the audit found that the state itself didn't even have policies or procedures for monitoring
Right.
the compliance. So that's big kind of first step is that you need to know how to do it in order to enforce it. And there was also this really interesting thing in the story about this ambiguity about who was responsible for parity. And
Right.
which I find to
Yes.
be disturbing because, ultimately somebody's got to be responsible for it. But the OIG in the report actually made explicit recommendations for the state to identify who should be responsible for this, which is, I guess a positive step in the right direction. But to your point, we're too many years into this to be getting it wrong still.
I'm glad you brought that part up because, right, like who is even the regulating agency
Hmm.
essentially? And it reminded me, I don't know how familiar you are with 340B. That may
Hmm.
not mean anything to you,
Yeah,
but there
of
was a
course.
longest time where HRSA was like, hey, we don't even know if we can regulate this thing.
Yeah.
So step one, who's in charge?
Yeah,
Step two, they should write out what you should be doing.
that's right. That's exactly right. And listen, Kansas is a great state. I love Kansas. Got friends there. This is not really about Kansas. I mean, if we had
Right.
OIG reports about many other states, they'd probably find the same thing that they found from Kansas.
Well, and I think even in this one, if I'm remembering right, I think OIG said, and CMS is like maybe not even doing what it's supposed to be doing with like 8 other states or something. I think that was in this report too.
Yeah, CMS made the decision last year to, um, I'll say this very carefully. They made the decision to not necessarily go after as strongly as they could enforcement of some of the parity regulations. And that
Right.
is a troubling thing, considering that many of us have been fighting for parity our entire lives. Now, I want to be clear with the audience that there is parity in law, which is largely what we're talking about here. And then there's parity in principle, which is just how do you really bring mental health to an area of priority within a state that it's treated as an equal across a
Right.
variety of different programs.
Right.
The law is just one way to get to that, but really there's a broader conversation to be had about why don't we do a better job taking care of individuals that are experiencing some type of mental health problem in their life.
Right. And I think, right. I mean, because nobody's just sitting around like, well, we really just want the law to be fine. No, we want what you just said to
Hmm.
to be the thing. And I think it's even more perplexing because I mean, I don't know about you, but I feel like in the last 20 years, we've come a long way just as like a culture in how we view mental health,
Hmm.
and reduce a lot of stigma around it, but we still are struggling for the funding and the payment policy, like in things like this to catch up to that.
That's exactly right. Yeah. I mean, especially after COVID, everybody could understand a little bit more what mental health was.
Right,
But unfortunately, a lot of the structures, the policies, the regulations that we have in place reinforce this very archaic dichotomy that mental is separate from physical. And we've just not been
right,
able to get over that. It's almost it's a little bit, Clay, it's like it's history and culture at the same time. We're fighting
right,
both of those things at once. But the general public wants more. It's just our systems haven't been responsive to meet their needs yet.
right. Thank you. Let's move on. I love
Yeah.
this next one. Because this one names names. So Hayers ranks by prior auth denial rate. So if you
Yeah.
didn't see this story, folks, it's a pretty good one. There's a couple different versions of it out there, but we actually now, I think it's yes for 2025 for most of what's in our world. So Medicare Advantage stuff, Medicaid managed care, and exchange, ACA marketplace. We now have ranks of who is denying prior auth requests the most or the least. And there's other things to get into there about like upon resubmission, who is approving, the second time or whatever. I'll let folks read the particulars. There are lists though. That I'm always looking for lists. I'm like, oh wow, I did not realize CareSource denied at this rate. Or
Hmm.
man, United, you're not as bad as I thought you were on this one thing. Or, I mean, I think the last thing I'll say on this before I let you cover this however you want,
Yeah.
but I think to me, the lesson, if you look at the resubmission and how much of the denials are overturned, the clear answer, folks, is appeal. Please appeal.
Yeah.
Whatever you do, please appeal because it usually works. But um, what do you want to say about this one?
Well, I mean, for folks that aren't aware, this is a 2024 CMS rule that requires us to publicly
Thank you.
post prior authorization and denial rates. So that's a
Right.
big deal because a
Right.
lot of what happens in healthcare is extremely opaque at best and a black box of, confusion at worst. So there's not a lot of transparency there. So this is it's a new on-ramp to try and give us a little bit more insight into what's happening behind kind of the curtain. And so this article I found interesting for a couple different ways. I mean, one, because I am your mental health guy today, this is something that really wasn't named in here. And I do think when you consider mental health as just an issue area, mental health and substance use crises are often acute and time sensitive. And so if there is a prior auth that comes into
Right.
play here and you're being told to wait, or you're being denied, that could mean the difference between someone starting treatment and getting better or someone showing up in the emergency department and costing you a lot of
Right.
money, or even worse. So it's really unfortunate. That was something I found quite interesting in here. Another thing that I think was a little bit troubling to me because I am an academic, and so I'm going to put my academic data hat on for just a second. The data they were aggregated across all services. And so there wasn't that breakdown that I wanted to see specifically around like mental health and SUD. And so it was really hard to compare that to like MRI or whatever
Right.
you know procedure that might be out there. So there's a little bit of transparency in name with this one, but it's not where it's needed most. We really need to have kind of this more opportunity to go deeper on that disaggregation of data. But yeah, it's fascinating. It is good to name names. They serve a purpose to have a different conversation. But there was a lot in here to unpack. And honestly, I have to say I was a little bit overwhelmed by how much was in this particular report.
Right. I think, I mean, to your point, I mean, I guess you were saying this is coming out of a 2024 rule, so it's fairly new,
Yeah,
right? So it's cool that we have, I think I want to look at this as a starting point,
yeah,
right?
that's great.
And I 100% agree. I am very interested in disaggregating by service types and lines or
Mhm.
whatever, because there's a whole the other side of the prior auth discussion. Some Medicaid community plans have gotten to where they just kind of take prior auth off of a lot of things,
That's
right?
right.
Like they will look and see, um, okay, wait a minute, 94% of the time we approve this thing. A lot of this will be like transitions from different types of facilities. So what are we even doing? Why are we not like auto approving it and then just review a sample later or whatever? And I think that's where you're only going to see that when you're getting down into like service type. And then
Yeah.
the other thing that I think particularly applies, at least in my limited slice in behavioral health and SUD and those types of things, there's plenty of things. The issue is not overutilization, the issue is underutilization. So
Yeah.
it'd be nice to see, wait a minute, why are we prioritizing that at all or whatever. So I do agree, like we really, the next study that comes out, the reg or whatever's
Mhm.
driving this does need to be changed to get us more granular data, because
Yeah.
otherwise, you know,
I agree. And I mean, listen, high fives all around. This is the first ever, and when is ever the first ever the best? So there's an opportunity to grow here. I do think there was another, as you were talking, there was another data point that I remembered here where they were describing how many folks were denied care. And I think it was
mm,
like roughly like 14 to 18% or something like that, 15 to 19%, something like that. But what was fascinating about this is that half of those that appealed the denials were overturned.
right,
So that tells me something that,
right,
we as like the general public, and I think folks that are on the more policy advocacy side of things really need to be doing a better job educating the general public. Hey, listen, just because you were told no doesn't mean that's the final answer,
right,
especially if it's something that you might need to fight for the betterment of your family's health and well-being.
right. No, I definitely think the lesson is appeal,
Yeah,
and I
yeah,
think just, most of us in the healthcare world, our family members are not in the healthcare
that's
world.
right. That's right.
And I think what I have seen when people get denials for things like for whatever, like, oh, I guess that's it. I'm like, no,
No.
trust me, like
Yeah.
no human he was even involved in this. I promise that some robot just telling you no because they know most people will not. But yes, encourage all your friends and family members to appeal the denial.
That's right.
Um, let's do this next one. I'm looking at the time.
Yeah.
This Arizona one.
Hmm.
Parents as paid caregivers under review of Arizona auditors. So the high level setup for folks that haven't been tracking this, lots of times family members can get paid by Medicaid as caregivers. Arizona is, there's a new audit in which their auditor general or whatever says, wait a minute, there's been a lot of growth in this thing. Also, they had like this, I think you can do 40 hours, get paid for 40 hours. But if there's like extraordinary circumstances or whatever, you can fill out this assessment. I think they paused that assessment
Hmm.
back in October. I think they say that it is like there's some lawsuits related to that. So they're like, wait a minute, we're going to stop using that thing. But I think the bottom line is auditors paying attention to this in Arizona. There's been half a billion bucks, 537 million surge. Clearly, it's a thing that's, you know, it's great for a lot of folks. It's also hard to control from like a fraud, waste, and abuse perspective. But Ben, what do you want to talk on this one?
Uh, so for anybody that's been a caregiver, you know how challenging this could be.
Right,
Nationally, there are 53 million of us who are unpaid caregivers. And so I have almost to a fault been focused on how do we better support these families that are taking care of loved ones in their life and not getting any compensation for it. So this one was interesting because they actually are looking at it from a couple different angles. And I guess that the bottom line here is that the auditors for the state didn't call this program bad at all. They just said that the state itself, to your point, Clay, they failed to implement the cost controls that lawmakers had already required. So they weren't doing the
right,
things you were supposed to do, which is encouraging to say like let's just don't get rid of it altogether because I think this actually
right,
does help a lot of families. But it's discouraging because almost like that parity conversation we just had, yet again, the state is in a position where it's not enforcing or doing what it's supposed to do to hold someone accountable. So I
right,
thought that was really quite a telling story. I want this one to work out for those families because I know how much this probably changed their life. But I also do know, to be just 100% blunt, I do know that there are folks that are not necessarily always the best actors out there. And
right.
we do need to hold people accountable for making sure that they're doing what they said they're supposed to be doing.
I mean, I think especially in this uh place of service and relationship, right? Like we can't
Hmm.
just
That's right.
assume that, I mean, if someone needs a caregiver in the home, they're like by definition pretty far on the side of the vulnerable spectrum, you know.
Exactly.
So we need to make sure that, and I'm sure 99% of them are great caregivers, but
Yeah, me too.
um it makes me think too, in a way, I draw a line to what we've been seeing in ABA. So
Hmm.
everybody kind of see, whoa, wait a minute, where did the ABA spit? Like for the longest time, it was like nobody was going to pay for it. And the next thing you know, it's like, whoa, there's a whole planet of spending called ABA. And
Hmm.
it's different from these in that a large part of that story is the private equity backing, that kind of thing. But
Yeah,
it's similar in that, to your point, I think there's general agreement of this is a great thing. But we need to get it right, you
that's
know?
right. We need to
Um,
get it right. Other states are going to be watching. I mean, this
right,
is a it's one of those things that I love about state policy work is that when you find reports like this or news lines like this, inevitably somebody's going to say, "Oh, and that's what they did, and let's do it better." And then hopefully
right.
state leaders come together and share. I care so deeply about caregivers. I think if, as I said at the top, I mean, if you haven't been in the situation, you don't know how hard it is to kind of keep a job, do all the other things, especially when you have a child or a family member with like a profound disability. It does take a lot from you. And so providing some type of support is a good direction. And this is just a state trying to kind of naturally adjust to doing what's inevitably right and figuring out there are some bumps along that road.
Yeah, I mean, for me, I hope whatever the litigation is that they said the reason they paused I hope that wraps up soon to where
Yeah, me too.
they can either say to the state legislature, "Hey, to heck with you guys, we can't do it anyway. It's illegal," or they can say, "Okay, cool, we're going to turn it back on because that's cleared up or whatever."
That's right.
Um, go ahead,
Yeah,
Ben.
I mean, and just another example of also not playing politics with people here. I think there is a little bit of partisanship that emerged here where some are saying, well, we're auditing this times 100, and then there's a million other programs out here that aren't being audited. And that
Right.
is just kind of unfair that you're picking on this one in particular. But yeah, I agree with you. Hopefully this will get, addressed relatively soon for those families that really need it.
Last one,
Yeah.
Colorado. Healthcare free fall. Finger pointing intensifies as Colorado's healthcare system strains under rising costs, shrinking coverage. It's such a headline for you. So I mean, I think in the headline, basically money's tight, and people are pointing fingers at each other in probably not just Colorado. What do you want to cover in this one?
So, as a former Coloradan, somebody who lived there for 15 years, raised family there, Colorado is in a unique position here, and it is interesting to read the headlines because there's two angles, and then I'll talk about Colorado's unique position. So, number one, you've got some state officials blaming the federal cuts, HR1, et cetera. You've got other officials, you could pick on which side I'm on here, that are looking at, well, the state's not done this right, and there's overregulation. So, there's both sides here. Now, Colorado is interesting because Colorado has this thing called the Taxpayer Bill of Rights, which basically it's called, or TABOR, which basically means that it's impossible for the state to raise taxes. So, what's the usually number one budget item on any state general fund? It's
Usually
healthcare.
Medicaid. Yeah.
Yeah, and Medicaid. So we're talking about how does a state right size itself and figure out a way to have additional dollars to support those loss of funds that aren't coming in anymore, while simultaneously not allowing costs to continue to grow uncontrollably. It is a perennial issue in the state. Anybody that's lived there or knows Medicaid looks to Colorado as a good example of what you can do and also a bad example of maybe what not to do.
Right. Um, how hopeful are you for Colorado's budget this year?
I'm never really that hopeful when it comes to figuring out that issue of Tabor that I mentioned, but I'm always hopeful for
Right.
Colorado because it's a beautiful frontier state that finds local ingenuity all over the place and comes up with creative solutions. They'll figure it out. They'll get there, but it is going to require leadership. There's new administration coming in the state. I think folks are they recognize this is a perennial issue and they will inevitably tackle it.
Thank you. All right, we got to ask you the question. It's a great conversation, Ben. Thank you.
Oh, yeah, thank you.
Scale of 1 to 10, how full of it is Clay Farris?
Well, I'm going to give you a little bit of a bump up today because of that shirt you're wearing, because
Thank you.
it adds some flair to this
Thank you.
discussion. So I'm going to give you a 6.73.
I love it. Sarai, we're back to higher numbers. I love it. All right,
It's great, Clay. Let's do this again, man.
Ben,
This is a lot of fun.
thank you so much for being here today.
Absolutely. Thank you.
All right, and up next, we're talking to Abner. It's so great to see Abner's been a long time. For folks that have been longtime fan of the show and our content and stuff, you probably recognize Abner from many, many years ago. Abner, if you don't mind, do a quick self-intro, what you're up to these days, and then we'll hop into the articles you wanted to cover.
Sure. So I'm Abner Mason. My current role, I'm Chief Strategy and Transformation Officer at Ground Game Health. And before that, I was founder and CEO for Same Sky Health. And Same Sky was originally called Consejo Sano. So Clay and I have known each other for a long time. So it's great to be back on the show, Clay, and great to get a chance to have another conversation with you.
Thank you. Thank you for being here today. First up, we got a couple of I guess deal or partnering stories. The first one is Healthy Together and Clear. I guess they're going to partner or already are to help states prevent Medicaid fraud. They announced this. It's going to have some biometric stuff in it. That makes sense with Clear. They scan my retinas every time I get on a plane. But then combine that for the, this need for Medicaid program integrity. What do you want to cover on this one?
So yeah, so I want to start with being positive. I think it's always important to be positive. So I want to say that I think this is a good step forward to see these two companies come together. It's a good use of technology, and we remain they're just starting, so it remains to be seen if there are going to be any kind of problems with people being able to do it. But I went and looked up again what it takes to get cleared, to be verified. And it's a simple, driver's
Right.
license or state ID, and you take
Right.
a selfie with your phone. So it seems
Right.
like to me it could be a really good way to establish identity. And all of us want to make sure that the Medicaid program is sustainable and that it can help the people it's supposed to help. And so integrity is really important. So I just want to make sure that I'm saying this is a good thing. This is technology coming together in a way that could make it easier for people, for states in particular, to make sure that the folks that are getting Medicaid are who they say they are. So,
Right.
thumbs up for the use of technology
Right.
to make sure that we know who people are. But with that said, I don't want I don't want people to confuse that good piece of news where technology is being used to identify people with what I'm really concerned about with the rollout of these of the community engagement requirements and the work requirements that are part of the H1. It's one thing to identify who a member is. It's another thing altogether to ask members who are struggling, they're low income by definition because it's Medicaid, they've got a lot of issues, to ask them to figure out how the work requirements are going to be implemented in each state. It's going to be different, and plans have to play a role there. What I have seen so far is that we're not ready. It's the end of August, and the full implementation happens in January, and we're just not ready. And I think plans and providers need to double down on, and states double down on their strategies to make sure that people don't lose their coverage because of administrative burden, because they can't figure out how to comply with the work requirement, or they can't figure out what the definition of medical frailty is. We don't even know across most states what the definition is. Those folks are exempt, but we're not sure what that means. So are people who have substance use abuse, but how do you define that in a given state? What does that mean? So I think we're not ready, and I'll just share this data point. I talked with folks from Arkansas. I had a long conversation with the guy who was at Arkansas Blue when Arkansas implemented work requirements. They were the state that I think did the biggest sort of statewide implementation. And he shared with me all of the things that the state did and the plans did in the lead up to implementing work requirements in Arkansas. And what's interesting is that what Arkansas did, they did a good job. In fact, everything that I'm hearing now that states are doing is what Arkansas did. Some people, sort of think, well, Arkansas, maybe they just didn't know what they were doing. Not true. They did a very good job, and still it failed. Still, there was enormous unnecessary loss of coverage. So I think we've got to be humble here. We've got to not allow some of the technology that people are throwing at this problem to cause us to lose sight of the fact that it's real people that even in the past when technology has been thrown at it, it just hasn't worked. And so my advice and I'll end here to plans and providers, because keep in mind, providers, particularly FQHCs who see patients, they actually have more at risk financially than even the plans, and the plans have a lot at risk. The advice I'm going to share is have a backup plan.
Mm-hmm.
Put together a strategy that so that if things don't work as people hope they will, and there is significant loss of coverage, there's confusion, there's lots of frustration. In early January, mid-January, February, have in place a plan. Put a contract in place now with folks who can help you to reach out to your members to figure out why they're not covered, and how to get them covered if they've lost coverage, how to ensure they stay covered if they're at risk for losing coverage. So that piece of work, figuring out who's at risk and reaching out to them and connecting with them. Put in place the procedures now. Don't wait until the stuff hits the fan, because it's very hard to figure out what to do then, and it will be a moment of sort of crisis. My advice is have a plan in place now.
I mean, I want to cover a couple different things you made me think of, but yeah, I mean, the providers themselves are the ones who know best which members are truly medically frail. Like, set aside definitional fights, but once that's settled, like if I'm, Dr. Clay, well, I know that those 4 out of my 50, like really, those are the ones I got to watch out. I need to help with that's my planning or whatever. And I even see in some places like behavioral health providers or whatever, they're being kind of proactive, and they're like, okay, well, here's the assessment we're going to use to prove that thing, and here's our form letter or whatever. But you're right, like people need a plan. Going back to the technology piece, you made me think of something. I mean, you're right. Clear is dead simple. Like they even I mean, they're even like when they see people in the full lines, they're like, it only takes 2 minutes and you can get signed up, and it really does. But you gave me another thought, and I'm joking when I say this. Are you familiar with flock cameras?
I've been hearing a lot about them. I don't know them that well, but I know they're
They're
very
terrible. And
controversial
I'm
right
I'm
now.
actually very anti-flock camera, but maybe we could bolt on flock cameras to this, and then we could say, well, yeah, Clay went into his place of work, so he's met work. That's all. All right, I'll leave on that note. Let's
On
go
that
there.
note,
A game changer, UHS, Universal Health Services, very large, has hospitals, I think, in like 30 states and hundreds of, or has 30 hospitals all over, and I think hundreds of outpatient facilities. They have acquired for 835 million bucks Talkspace, which I think is a behavioral health provider
yeah.
service remote network thing. Um, and yeah, it's going to get them 6,000 behavioral health clinicians. It's already getting, $280 million revenue a year, it looks like. And then I think the bigger vision here is Talkspace providers could steer into UHS facilities. That's my understanding of it. What are you thinking here on this story?
Yeah, the thing that interested me about this actually was more sort of the bigger picture of what this shows. So, UHS is a huge health system,
Right.
and you and I, Clay, are old enough to remember when Teladoc was at war with the medical board in Texas.
Yes.
This reminded me of because when telehealth was first sort of being introduced in the US, the physicians were very much against it. They thought it
Right.
was the worst thing in the world to have virtual care, and they were insisted that you had to be in the office. And Doc waged a huge battle the medical board in Texas. Ultimately, technology and I think more progressive thinking prevailed, and COVID really pushed forward
Right.
the need for virtual care. So it dramatically pushed it forward. But the first thing that this article made me think of, and I thought we should it's because it ties to the second thing it made me think of. First, that things change, that technology
Yeah. Yeah.
forces us to change. And it's actually to me an optimistic kind of note here that you can have a significant part of a whole sort of group doctors who were, and it wasn't just Texas where they were opposed. They were opposed across the country, where it completely flips. The technology eventually proves itself,
Right.
and you have doctors who then figured out how to make it work for them. So here's a health system that is making a virtual care company system
Right.
work for them. They're saying this is the key part of the way we keep doing what we do and we keep growing. So I think that's really kind of cool, actually, if you think about it, because it wasn't that long ago that they were at war.
Right. You're right. You made me. I did not have on my bingo card buying behavioral health network as a strategic direction. 5 years, 5 years in a remote behavior or whatever. You're right. You're right.
Yeah, yeah. And the other part of it that I think is interesting, and this is just jumping off the article. The story is a jumping off point, but they mention it just before the acquisition closed. Talkspace launched a AI therapist. They call it T. It's an AI therapist, and a couple things about that. One, they're not the only ones to have done it.
Yeah.
There are a number of them now in the market. The world is changing. So I'm sort of tying it to the technology story. First, it was virtual care, and now it's AI therapist, which is kind of the next, like the next
Right.
level
Right.
up in terms of technology. And what we're finding, and there's a lot of data on this, and in fact, the article links to some of this data, is that younger people, kids who are growing up with AI, they see it completely differently than you and me. I think I'm older than you. So we remember a world when AI didn't exist, but
Right.
younger people growing up, they don't know a world where it doesn't exist. And so how they view AI in healthcare is going to be dramatically different from us. And even 30-year-olds, this article notes this, even 30-year-olds, which is not kids, 30-year-olds are twice as likely to be willing to use and happy about using an AI therapist as folks who are older. So we're already seeing it. So, and then I'll just, because I'm sure you have a comment here, I'll just end with this. Just in the last 48 hours, I've been reading on LinkedIn. There's a big discussion. A guy named Zeke Emanuel, who I have a lot of respect for at UPenn, wrote a piece, I think in the New England Journal or one of those journals, saying that basically AI was going to replace doctors. And so there's a huge raging debate
Right.
that's going on. But my point is that just as we saw virtual care uh, be something that was frowned on by the medical industry, and now the medical industry is embracing it, and you've got leading, health
Right.
systems including it. I don't think it's long before we're going to see AI not only just doing therapy, which is now happening, but I think Zeke is onto something. And so I'd encourage people to take a look at Zeke Emanuel's piece, the article he's written, because it's a very interesting debate going on.
I mean, I don't see how it's not. I mean, it's maybe even already there as far as replacing doctors or, I mean, there's a spectrum here, right? Like, I think most people have been using ChatGPT for a while at a
Yeah,
minimum
yeah,
to get a
yeah.
second opinion or whatever. And even before that, it was WebMD. You want to talk
Right,
about
right,
dating
right.
yourself.
Right. And a
But
key point here is cost. The
right,
cost of these modalities is so
right,
dramatically less that
right,
it makes it possible for people to get care. And I think the issue is it great care? And Zeke Emanuel is arguing there's not just good, it's great care. I think
right,
we're going to have to prove that out. I tend to be lean toward the Zeke Emanuel side of this, but if you, but there's that old saying, we shouldn't let perfect be the enemy of good.
and it look good,
If
yeah.
people can't afford healthcare at all, then having something that's good that's easy for them to access
Right,
is something that we should embrace. And for Medicaid populations who struggle, particularly in the current environment where people are going to be losing their coverage,
right.
we should be celebrating these solutions that are low cost and I would argue are good quality. And I think that Medicaid programs themselves should be embracing some of these technologies because
Right.
looking down the road, the squeeze that's on Medicaid, I don't think it's going to get less anytime soon. So if you
Mm.
want to do more with less, technology is the way to do it.
I think the real, and I don't know where we will cross this point, but when more people realize that AI is of a higher quality than most, and I'm speaking for myself, and it's all a
Yep,
matter of how you use it and all that kind
yep,
of stuff.
yep, yep,
But I have been to the point where I trust what I get out of what I do with AI on many things way more than I do myself or a physician or
yeah,
whatever.
yeah,
I don't know where that, because in general, I think people still think like, oh, that's just AI slop, which a lot of it is. But at some point, we'll get to the point where it will be clear
yeah,
that you're actually taking more risk by just having one or two humans look at your medical record or
yeah.
whatever.
I think we're heading in that direction. And for Medicaid, it opens up a huge door of opportunity for low income people to get
Right,
great care. Because
right. I
we
mean,
don't have the resources to
if
do
I
it the
can't
old
get you
way.
into a visit for 6 months, can I at
Right,
least pay $20 a month for you to use ChatGPT on me?
right,
You know what I mean?
right,
Come
right,
on. I mean, why
right,
not?
right.
All right. I know you've got a case study you want to talk about. I want to make sure we get time for that.
Yep.
Tell me about it. I mean, you sent the link and it's some stuff I think that Ground Game's done, but tell us what do you
Yeah,
want to cover?
so this is some earlier work. The white paper the paper I want to actually talk about was just published in the New England Journal of Medicine a few months
Okay.
ago. So that's not this. It's a white paper. I can share with you the link so that your guests can see
Please
it.
do, yeah.
But it was published in the New England Journal of Medicine, and it is about the work that Ground Game Health has done with Elevance. And I'm super proud of this work. Elevance wanted to solve their member social needs. Elevance realized that social need was getting in the way of the clinical journeys, goals they had for their members. Social need meaning food insecurity, housing insecurity, domestic violence. not having transportation, all sorts of social issues were getting in the way of the clinical goals for that member. And this was true across Medicaid, Medicare as well, Medicare Advantage, and commercial. It turns out that social need is a commonality across all those lines of business. And also the ACA. Certainly it's worse probably in Medicaid because by definition, people are low income and really suffer from the social determinants, but it's true across all lines of business. So what Elevance did, what I think is really smart, they partnered with Ground Game Health and they said, look, we want you, we're going to refer these members who we have identified have a social need. You reach out to them, you verify they have the social need. You then use your services and community-based groups local to the member who you contract with to solve that member's social need, figure out a way to keep them housed if they're at risk for losing their housing, or get them housed if they need housing. If they need food, figure out a way to get them food tonight, and then figure out a way to get them signed up for SNAP so that they solve the problem more generally. If they've got domestic violence, figure out a way to get them into a safe place. Obviously, these are high-risk members. And to Elevance's credit, they said we think by treating the person as a whole person and not pretending that the social isn't important and just the clinical is, we know that doesn't work. If we're not going to ever achieve our clinical goals if we don't see the person as a whole person and deal with all their issues. And so by contracting with Ground Game, they let Ground Game do that work. We reached out to the member, we verified the need. We connected them with a local community-based group. We got the need solved. We then verified that it was solved and shared that information back with Elevance. That's what we've been doing for the past 4 or 5 years. What's amazing and really cool about this is that Elevance said we want to do a peer-reviewed study. We want to take all the data, the cost to us of managing these members, and look at the folks that GGH, Ground Game Health, has interacted with and the folks that they didn't. And when they did that, they found that there was a positive ROI, a really good positive ROI for solving social need. And the reason I bring this up, why I'm excited about it, and I think it's really important, is in the current environment, it's really hard for health plans and others to solve the member's social need because there's so much financial pressure on the system. Health plans are cutting back. They're getting out of Medicaid, as you know, in places. There's a lot of financial pressure on the system. And frequently what happens is it makes it very hard for plans who know that they need to treat the whole person and to solve these kinds of challenges for the member, but it's hard to make the case internally. What's missing is data, is analysis, is proof that this is not just the right thing to do. And it is. It's the right thing to do. Getting people food and housing, that's the right thing to do. But it's also the smart thing financially. It's a very attractive return on investment when you invest in a smart way. You can't just throw money at it. You have to invest in a smart way. And I think that's what Elevance did by partnering with Ground Game Health. So I'm super encouraged by the data that we as peer reviewed, and I would encourage, here's my ask, is that plans and across lines of business, certainly, but also providers, look at the study and show it to your CFO, because we can't let the current environment cause us to lose sight of the fact that the social determinants of health do matter. And if we don't address them, we'll never achieve our goals for people. And that's not right for people. It's also not right for the economics of healthcare. So we need more studies like this, but this is an amazing one. So I just want to share it.
Yeah, please do get us the link, and we'll get it like on the show notes or whatever. Thank you. All right, I got to ask you the question: scale of 1 to 10, how full of it is Clay Farris?
I'm going to take the easy way out, and I'm going to say that a guy who dedicates his career to a program that is all about helping people who are poor and don't have a strong voice in our society, who are easy to look down on, easy to not care about. A guy who commits his career to that population is a guy who has a lot of love in his heart. And I'd give you, if we're measuring it by love in your heart, you're 10.
Thank you. That's very, very kind of you, Abner. Thank you. Thank you for being here today.
Glad to be here.
All right, let's move on to Job Hunter real quick. Again, just a quick plug for all the great work the research team does. In each of your Intel reports, you will see the different job listings they have found. Over the years, we have lots of folks ask us who's hiring or who's out there looking for a job. And so we select job postings that we think each of you might be interested in your group. So check those out in your Intel report. Now let's do Grab Bag. First up in Grab Bag is going to be acronym of the day. We'll do that. Today's acronym is MAGI, M-A-G-I. Folks have been around for a while. I remember when this kind of came on the scene, but if you're new, that's Modified Adjusted Gross Income. Again, shout out to the team that does a great job with these infographics. Make sure you're checking those out. If you're watching the replay here, just hit pause, but I think you can see these in your Intel reports too. But if you think of MAGI, it's kind of a quick down and dirty formula to see if Clay is eligible for different Medicaid programs. It's an income calculation. It stands for Medicaid Adjusted Gross Income. It's been around for quite some time, and actually now it's part of the work reporting rules. So acronym of the day, check it out, MAGI. Mission Possible, we're almost done here. This week's Mission Possible is to look around and see what other people are doing in your area and support them. So look around your community, find a program or a partnership or a system or even just a neighbor that's maybe helping others out and figure out what you can do to help them. Sometimes it's not about starting something brand new. Sometimes it's about supporting people that are already doing something. If there's somebody you find and you'd like to let us know about it, find us on LinkedIn and tag us just to celebrate the good work that is happening close to your home. And that's it for this week's Medicaid on the Brain. Thank you for joining us. Thank you for being a part of what we are doing. Thank you for letting us be a part of what you are doing. Hopefully this is helpful to all the great work that you are doing in the Medicaid space. Until next week, I will see you again on Medicaid on the Brain. I'm signing off, Clay Farris.